Okay, so what I'll talk about now is this project that has just got underway. And so I'm not going to be presenting any results. I'm just going to be talking about what we've got planned for this research, really. And as I say, it's just getting underway. It's got 4 components. I'm going to talk about mainly one, touching a little bit on the second component that offer leads. And there's a couple of other components on whakapapa research and life course research among Māori. They're all funded from the same kind of pool of money from the National Science Challenges, Better Start Healthier Lives and Aging Well. So my component and offers as well is about the impact of chronic health conditions on families across the life course. Ideally, we'd like to look at families in whānau, and offer may be able to do that, but in what I'm going to present using the administrative data that we are left with using, I don't think we can really get a good conceptualization of whānau, so focusing on families or people within households technically. And the basic idea here is that chronic conditions, things such as cancer, cardiovascular disease, diabetes, mental health and obesity, and they are the focus of one of the National Health Science Challenges, Healthier Lives. They're a leading cause of premature death and disability across the world and in New Zealand. And in New Zealand, there are high rates among Māori and Pacific populations. And the impacts to the individual on functioning and quality of life have been well established, such that the Healthier Lives National Science Challenge, which has this as its focus, isn't so much looking at the impacts on the individual on functioning, because that's well known, looking at more interventions and other things that can be done. And just to give you a sense of how it may have an impact in New Zealand, what I've got shown there is from the Global Burden of Disease, looking at the major causes of death, top 10 from 2009 and 2019. And you can see there in the, we're calling that a bluey color, are we? In the blue color, we've got all the chronic conditions and they're dominating. And a respiratory condition, lower respiratory infections, has rocketed up the order from 2009 to 2019, but all the rest are chronic conditions. So they're the major causes of death in New Zealand and worldwide. This research here, this research was done by, I hope you can see that, Sylvia Dixon at the Treasury. This was actually a test case for what value there would be for adding health data to the integrated data infrastructure. So this is when they were just proposing a case to put health data in there. Before that, there was the longitudinal business database and IRD data and a few other bits and pieces in the IDI. So what Sylvia did is she looked to see what are the impact on employment and income in the months and years following diagnosis, as far as the health system can tell, of various chronic conditions: stroke, traumatic brain injury, coronary heart disease, diabetes, chronic obstructive pulmonary disease, breast cancer, melanoma, and prostate cancer. And you can see the differential impacts there. So for instance, stroke has really big effects on both employment along the top 1 and 4 years later, and also on earnings. But things like breast cancer, for instance, has a strong impact on earnings in the first 12 months, but less so in the 3 years subsequent to that. Anyway, point is, to the individual, chronic conditions have lots of impacts that aren't just health as well, on earnings and employment and that sort of thing. And this shows you the impact of ethnicity and deprivation on a chronic condition, chronic obstructive pulmonary disorder. These are hospitalizations in adults aged 40 years and over. This is from the Health and Independence Report 2017, put out 3 years ago now. And you can see there's strong gradients shown in the different bars for each ethnic group there by ethnicity. We've got NZ depth quintile going from least deprived in the lightest color to most deprived in the darkest color, and big differences across ethnic groups as well for that particular condition. Focusing now on diabetes, this here shows percentage of New Zealanders with diabetes by age, broken apart by ethnic group. And there's lots of things that stand out here, one being that increases with age, but also once you get to the age of about 60 or 65 and you're Pacific, you've got about a 60% chance of having diabetes. So really big impact on New Zealanders and some New Zealand subpopulations. That's all known. What's less known is the impacts of the family. So if someone is living in a family with someone with a chronic disease, how are they impacted? Little bits of work have been done on this, but not much, and this is where we want to fill the gap. Where there has been work done, the focus has tended to be on either carers, and when they focus on carers, it tends to be specific types of carers, typically older spouses living with another elderly person with a chronic condition. Or there's quite a bit of work on the impact of children of having a depressed mother, and some work on the impacts of parent of having chronically ill children. So I'll just summarize these briefly, and then going to what isn't known and where we can potentially, we hope, fill the gap. So in terms of carers, most research, as I say, is focused on specific types of carers, but this particular report, using data from the Canadian General Social Survey, looked across the board. They investigated who was a carer, and they looked at general effects. And they found that carers report greater loneliness, isolation, they did less exercise, and had greater alcohol use than non-carers. In terms of older carers, there was an annual review or a systematic review put out in the Annual Review of Psychology last year by Schultz et al., and found that older carers, there's good evidence from a number of studies that they experience psychological distress, have adverse health outcomes, have lower relationship quality, and may have their work impact, although the evidence is mixed on that. And then there's a number of studies by Kelly Schaffer and other people that she works with, focusing specifically on carers of cancer patients. And across the research that she's done, she's found that cancer carers have worse mental health, physical health, and sleep is impaired. In terms of parental depression, just jumping down to the third point there, parental depression is shown to increase the risk of depression in children. There's been lots of research done on this in the sort of family history and behavioral genetics space. Myrna Weissman has now got a 3-generation depression study showing that depression in the grandparents affects depression in the parents, and depression in the grandparents and the parents affects depression in the 3rd generation as well. And Wickersham as well has looked at the impact of, that has shown that children are more likely to have depression if they have a depressed parent. Also, some studies showing that parental depression has a negative impact on childhood obesity, on children behavioral problems, so acting out, and also children of parents with depression are more likely to experience maltreatment, and this tends to be across the age range from a young age through to adolescence, about the same increased risk across those years. Limited evidence, because there's been limited people looking for the impact of physical health of children as a function of having a parent with depression. And then there's been little bits of work done on parents who have ill children to show that they have increased anxiety and depression, more likely to have early mortality and cardiovascular disease. That's a specific study looking at parents of children with congenital abnormalities based on a systematic review. So in terms of impacts on the families, we think there are gaps in the literature that we can fill. Specifically, impacts of parents with chronic conditions on children. So there's been investigations on carers and investigation of parents specifically with depression, but not parents with other conditions so much. There's been some investigation of education and socio-economic outcomes, but I think more needs to be done in that area. And as I mentioned, the evidence is a bit mixed. Looking at the full range of family members hasn't tended to be looked at. There's been focused on certain types of family members, particularly spouses or sometimes children. Also the full range of carers, again, not just focusing on spouses, but other people in the household who may be carers. And we think we can make some sort of impact there. The other thing is, I mean, there's basic descriptors here as I'll get onto that we can look at, but I don't think there's been a lot looked at in terms of the impact of multi-morbid chronic disease sufferers and their impact on family members. So where someone has not just got one chronic condition, but has more than one chronic condition. and what impact that has over and above having one. Then, of course, there's multiply affected families, families where there are more than one person with a chronic condition. And is the impact worse, or is there some protective effects of living in a multi-generational family where there are potentially more people who can help out? And then, as I say, I think just family level descriptors. There's good descriptors about how many people in the population have the different chronic conditions, but not a lot of good information about how many families are affected by people with a chronic condition. If you think back to that earlier slide, which showed that once you get to age 65 or so, 60% of Pacific adults have diabetes, not to mention other chronic conditions. Think how many families that must affect. And the other things that we can do, I think, less on in our study of quantitative study of whole population data, but I think often can contribute to with the qualitative study on Tokelauan population, as I'll get on to, are things about positives and resilience. So are there positives of being a carer, say, of someone with a chronic condition? That's not something we can really look at too well, I think, with quantitative administrative data, but in speaking to people, it's something that we can unpack a little bit. And a little bit of work has been done. Why do we think this is important? Well, one reason is that estimates and projections for disease burden are likely to be greatly underestimated. So I've got a picture there of the cover of a report that was put out, I think, earlier this year, put together by PwC, but sponsored by Diabetes New Zealand and Healthy Lives Natural Science Challenge and a few other people, Edgar Diabetes Centre, about the economic and social cost of type 2 diabetes. So I went through the report because we're just about to start this project thinking, I wonder if they've looked at the impact on family, whānau and friends. And they mentioned once that the condition, diabetes, can have a profound impact on the person's family, whānau and friends, but then they move on because I don't think the data are there to cost it, which this report wanted to do. And what I suspect we might find is if we can actually get to the point of identifying the impacts on the wider family on having someone with diabetes and other conditions, then eventually that can be worked into costing models of the burden of disease. So not just focus on the individual. Secondly, I know there's been a little bit of work on this, but I think by doing a bit more, I think we can engender greater recognition and support for the role of carers. Again, just after the study got underway, I was made aware of someone who just finished their PhD at the University of Auckland, who did a qualitative study on child carers, so children who are looking after other people in their household. And we've got in touch with them, we're going to work together on some of these things. But it became clear in having discussions with her name's Lauren Donald, is that the extent of caring itself is likely to be underestimated. One thing she found is that when she went to interview carers, in the process of discussion, they both realized that the person that they were caring for was not necessarily the person that they thought they were caring for. So there may be situations where, for instance, there's a parent with a chronic condition or some condition, and they are looked after by the spouse. And as a result, older children looking after other children in the household, that wouldn't otherwise happen had there not been someone with a chronic condition. And because of this connection with Lauren Donald, we're going to have a little subcomponent work on the role of young carers. And I know Offa herself has done lots of work of young carers in the Pacific population as well. And again, coming back to that point that there's acceptance that I think we can probably get at best through qualitative data, that caring may be rewarding as well as instead of being a burden, or perhaps it's both. And slightly more provocatively, if we accept that the burden is underestimated because people have only looked at the impact of the individual, not on the impact of the wider family, then should this be factored in when deciding treatments to fund? If the idea of the government funding treatments is to improve the health and well-being of its population, should you only consider the person with the chronic condition or the condition, or look at how, if we improve that chronic condition, we're going to improve their wider family as well? I think there's a good justification for thinking the latter, but there's not the data there at the moment to do that, or a long way from it. But I think we might be able to contribute to that. Okay, so the basic idea for the study that I'm leading is to determine the influence of chronic disease on the wider family at different life stages. with a focus on 4 areas: children, households, partners and carers, and older adults. This is going to be a quantitative investigation using the integrated data infrastructure administrative data. Alongside this, and both of these are underway at the moment and at various stages of their research path, offer is looking to determine the family, household and community strengths that allow people in the Tokelauan community who have particularly high rates of some chronic conditions, I think the highest rates of diabetes. So the diabetes is higher amongst Pacific populations generally, but highest amongst the Tokelauan population. So what are the strengths in the family, in the household, in the communities that allow the Tokelauan community to thrive despite the challenges of living in families with chronic disease? And that's going to be an in-depth qualitative study, which I won't go into in great detail, but anyone who is interested in that can talk to Offer about it. I've got one slide about it later, but that's about the extent of it. And we're going to work off each other so we can produce some data about the prevalences and the number of families affected and that sort of thing that can feed into the work that Offer is doing. Okay, so we've got a team together to work on this. I'm leading this, and the data management is being done by Lisa at Compass, who I mentioned in the introductory presentation, who's a senior research fellow at Compass. Andrea Teng, who's at the University of Otago, Wellington, and has been involved with the Healthier Lives National Science Challenge and is a medic herself and has published a number of things on chronic conditions. And in terms of the 4 different areas we're looking at, Lisa is going to lead the investigation of children and families. Then for the work on partners, this is going to be led by people at the University of Queensland. Janine Baxter is the principal investigator there. She's at the Lifecourse Centre at the University of Queensland. And that should say Martin O'Flaherty, Jack Lamb, and Yanshu Huang, who Lara and I both worked with, who used to be at the University of Auckland, but is now at Queensland. And they're going to be working on this. So the ideal world is, in January, they come back to New Zealand and work in the IDI, but we'll see how that goes with lockdowns and everything, the way things are happening. And then we've partnered also with Hamish Jameson, who's an older age researcher at the University of Otago, Christchurch, and Ulrich Bergler working with him to look at the impact on elders of having someone else in the family with a chronic condition. And they're also working with Lucas Marek at the University of Canterbury. Okay, so the basic idea there, so I'll take a step back actually, both literally and figuratively. We're funded by the 3 National Science Challenges, and they came to us and said, we need to do something on life course research, what can you do? And we can't fund anything in terms of new data collection. And we realized in order to do life course research, you need long data, and really it just doesn't exist in New Zealand. We could wait, I mean, there's the cohort studies that go up to the mid-40s at the moment. But in terms of administrative data, there's nothing much else that goes for a long period of time, given that the administrative we've got, some of the data sets are only available for the last 15 years or so. So what we thought we could do is focus on the middle part here of the life course, the component that's the focus of the Healthier Lives National Science Challenge, the chronic conditions, and look at the impact on people earlier in life, as well as later life, and how that may develop as they develop across the life course. So what we've got here is the things that are of interest to the Better Start National Science Challenge, healthy weight, successful learning and literacy and teen resilience. We've got the things that are of interest to the Healthier Lives National Science Challenge, obesity, cancer, diabetes, cardiovascular disease and other chronic conditions. And the things that are of interest to the Aging Well National Science Challenge, healthy behaviours, healthy lives, healthy minds, healthy bodies. And we can investigate across that life course without having the long data to do so by looking at the impact of chronic conditions of family members at different stages. So the impact on children, the impact on elders, and the impact of people of the same generations. And as I say, with a focus on children, partners and carers, families, households, and the impact of multi-morbidity. To do this, as I've alluded to, the focus is going to be working in the integrated data infrastructure. There'll be a few other talks after this that are talking about research using the integrated data infrastructure. Many of you may know this. For those who don't, it's a whole level data infrastructure made up of data sets from different government agencies, mainly linked at the individual level and made available for research. So for our purposes, there's information in there from the census in 2013, which allows us to define families. That's one of the few ways you can define families and households in administrative data, because it's not routinely collected, except for a planned collection such as the census, and look at impacts thereafter on family members, both in the areas of, I'll run through them. So they've got benefit and social services. Do people leave the workforce, for instance, if you're the carer of someone or you're someone else in the household? Education and training. We had a discussion about this at a whānau that Offa put on maybe a month ago now. And there was a good discussion of people who'd known other people whose children had to leave school early to look after other people in their families. There's a wide range of health data sets there that we can look at. Again, followed at the individual level. So we know that, for instance, this person is in a family that's got some of the chronic condition and this person is not. And we can look at their outcomes over time. So that's the basic idea. So I've mentioned some of this, but focus on the chronic conditions, using data from hospitalization data, pharmaceutical data, lab test data, outpatient data. The Ministry of Health has come up with a definition. Well, they had a chronic conditions data set that defined 8 chronic conditions, and they had definitions of how they define those chronic conditions that involve using these data sets. So we've gone through and done that ourselves. And we can look at its impact on healthy weight using data from the before school check, for instance, which is a whole population screen of 4-year-olds, amongst other things. They measure height and weight. Successful learning and literacy. So looking at educational attainment in children in adolescence, the earliest measure you get from the educational data that the Ministry of Education and NZQA provide is NCA, so age 15, 16, 17. And teen resilience in terms of whether they may or may not be experiencing mental health conditions, which we can find out from pharmaceutical use and the community treatment data set primed. As well as, the thing about starting with big data is if you need to, you can go down and make it small. We can potentially look at survey data here from the New Zealand Health Survey, which is now in the IDI. Some restrictions on how it can be used, but it is now in the IDI. And then in terms of how it might be affecting elders or others in the family, we can look at their hospitalizations from the NMDS, their outpatient attendances and their ED attendances from NNPAC, and their own chronic conditions, which we can define. How they're doing in terms of healthy minds and their mental health and well-being from the community treatment centres and the pharmaceuticals, as well as some surveys, New Zealand Health Survey, the General Social Survey. How their lives are tracking, looking at, again, survey or collected data from the census, the General Social Survey or Household Labour Force Survey, and their healthy behaviours from New Zealand Health Survey. So, as I mentioned, the idea here, and we're at this stage really at the moment of setting things up, is to define and characterise households, define chronic conditions among household members. There's the 8 that the Ministry of Health define: acute myocardial infarction, cancer, chronic obstructive pulmonary disease, coronary heart disease, diabetes, gout, stroke, traumatic brain injury. To that, we've added a couple more. Mental health, because we think it's really important and should be looked at, and also dementia, because there's going to be an elder focus in our research. And then, as I say, we want to answer some basic descriptive questions that have not been answered before, such as just how many families include a family member with a chronic condition? How many families include a family member with multi-morbid chronic conditions? How many families include more than one family member with a chronic condition? And do any of these things differ by socioeconomic status, ethnicity, and family structure? And then we'll get on to a series of questions that are focused on the different life stages. So how are health, education, and wellbeing outcomes for children impacted by living in a family with a chronic disease? How is the employment, income, and physical and mental health impacted over time for the partners and carers of chronic condition sufferers? How is the health, mental health, and lives of the parents and elders of chronic condition sufferers impacted over time? And how does having a family member with a chronic condition change family and households over time? So one thing we've also got in the integrated data infrastructure now is a second snapshot of family structure from the 2018 census. So there's a 2013 census in there, the 2018 census in there, which didn't go as well as the 2013 census, but nonetheless, for some people, we can track how their household structure may have changed over time. Len, knowing that the household structure data wasn't very good in the 2018 census. Yeah, so that's the basic idea, sort of 8 research questions. And surprisingly, I'm really interested in the descriptive questions first to see just how many families are affected. I'm not aware of data out there in the world that shows this. We plan to run analyses in the whole population as stratified by major ethnic groups, European, Māori, Pacific, and Asian, as well as running planned subgroup analyses for the Tokelauan ethnic group to help out offer with her work. And we didn't plan to do this to start. When we were discussing this, we were thinking, do we want to really focus in on specific chronic conditions or look at chronic conditions as a whole? And what we put in as a plan actually was to look at chronic conditions as a whole. But the more we thought about it, we thought we really have to look at different chronic conditions. As shown earlier actually by that Sylvia Dixon research, showing that different chronic conditions have different impacts. And we're also having discussions recently about how we might be able to get some indication of functional impairment of specific chronic conditions, or on the individual who may have more than one chronic condition. And we'll try as much as we can, as much as the data will allow us, to identify predictive factors. So is it fine for you if you've got lots of other members of the family who can do the heavy lifting in terms of looking after the person with a chronic condition? So number of disease-free family members. Is it better if your socioeconomics aren't impacted so badly that you have to move around a lot, or you're precarious to start with and have to move around a lot? There are clearly limitations here. And I work with administrative data a lot, and the more I work with it, the more I realize how many good things you can do with them, but how much is missing from those data. So analysis of administrative data generally, but for this project specifically, is good for understanding what is going on for populations. But if we find an effect, for instance, children are less likely to stay in educational training, we have no idea why it came about. We just can see it in aggregate. But we can't dig deeper to see what might be going on here, or mostly we can't. And where we find an effect in aggregate, that might mask lots of different things going on for individuals. So in aggregate, you might see that in the group who are living in a family with a chronic condition, they are 10 percentage points less likely to stay in education, controlling for various other things, than children and families without a chronic condition. But still, there'll be lots of kids who do carry on with education and training. So there's going to be lots of individual differences going on there. As I've mentioned throughout, we can focus mostly only on negative outcomes. We can't, I think, uncover all of the positive impacts of, for instance, caring for a family member. And this is why I think it's extremely important that we augment our findings with in-depth qualitative analyses that Offer is going to be working on. So just briefly on that, and I hope I do a good job in this one slide, Offer. The project is called Intergenerational, Integrative and Intellectual Pacific Property and Pathways for Life, IP for Life. And this is just a repeat from the earlier slide. It looks to determine the family, household and community strengths that allow people in the Tokelauan community to thrive despite the challenges of living in families with a chronic disease. And to this end, there will be an interview that will be involving the Tokelauan, or will be involving the Tokelauan community leaders, and there'll be research interviewers going into homes and interviewing community leaders who can speak Tokelauan. And it's kind of a co-researcher model where the people who are part of the research can shape the way it travels as well. Qualitative investigation in 2 sites, one here in Wellington, where 53% of the Tokelauan population live. Another in Auckland, which was a suggestion as part of a review, wasn't it, Offer, I think, that we focus on Auckland as well, where a quarter of the Tokelauan population live. And there'll be purposive sampling through collaborating service providers. So that's Pacific Health Plus, is it, and the Tongan Health Society in Auckland. Yep. And I guess that's who we're visiting this afternoon, is it Pacific Health Plus? Excellent. Okay, in terms of what we hope to contribute here, Well, I hope we contribute to policy development around support needed for families. I hope we better capture the wider impact of chronic conditions for each chronic condition. And as I mentioned before, I hope this can contribute to cost estimates and maybe eventually treatment funding decisions. That might be a rather long bow, but we'll see. But I think also by doing this, others maybe as well, want to raise awareness that what happens to individuals not just affects them, but affects families, and that this should be taken account when people are undertaking research. So a move away from an individual focus. And so that's a core part of what we're doing, and maybe others will look at this and see, hey, actually we do need to consider the effect of whatever exposure they're interested in, not just on the individual, but on the wider family, or even wider than that, people that they may interact with. Anyway, thank you very much for that. Thank you for the extra time that I was able to get there, and break now for questions. Thank you very much. Yeah. We're just having a discussion about that now. So one of the things that have come up, there's actually how their health is impacted. So for instance, someone with diabetes, have they had an amputation, that sort of thing. There's been other discussions, and all the things, for instance, that Sylvia Dixon looked at. So has their employment and their income been affected? There are other things that we can do that we're talking about. So have they had to give up their driver's license? But we had a meeting like early in the week, I think it was, to discuss a range of things we might look at. And Andrew Ting, who's an expert in this area, is going away and sort of putting together a list. And I think the way we're going to work is just have a look at all the impairments that people with chronic conditions have, and use that as a very indicator whether they have one or several chronic conditions. So not make it, in other words, not make it disease specific. Given chronic conditions are based on admin data, presumably mostly via hospital farms and labs data, there are likely undercounts of people and families who have chronic conditions but not use health services. How do you take these into account? Thanks. Well, I think you're absolutely right to some extent, although I think for the physical health conditions, most people would eventually be picked up by the means we look at. So, you know, so like you've got diabetes and you haven't had a lab test for HbA1c or something. So we can look at those sorts of things. This becomes more of a problem for mental health. This is something I'm quite keen on emphasizing, that what the IDI contains is service use for mental health, not mental health suffering generally. I think this is a limitation of the research generally, not something we can especially address.
My question relates to the severity of the condition. What about the level of care that carers actually provide? Because some people might only be doing part-time, or might just like some independence, or they might also be able to, because of the socioeconomic condition, can actually hire a carer for part of that time as well. So there is a lot of different levels hands-on would be providing to families.
Exactly. So the question is, can we even account for the level of care being provided by a family member? And I think the short answer to that question is no, we can't. We got some information on who is a carer reported at the census, but there's also a question of whether that captures well enough who is acting in a caring role. I think mostly what we can do is look at the impact on family members without saying exactly it's because they're acting in a caring role and the level of care that they're providing. But you're absolutely right. It came up at the whānau actually, that where we might find, for instance, social economics plays a role here, and that people with social economic resources aren't as badly impacted. That might be because of outsourcing, but that's just speculation. If we find that, our interpretation that it might be because of outsourcing will be speculation. We can't dig any deeper, which, as I mentioned, is one of the limitations of the admin data.
There's limited information also with service speaking of specific families and the caring services that they have. Not all families are aware of those types of services, so there are service providers in the community that we will be able to talk with, find out additional information they're receiving, but then again, are those types of services adequate? Is 1 hour, a day or a week sufficient for someone who has a long-term chronic condition? So we're seeing that it's the family themselves that are carrying the bulk of this support within the home, and for nothing, they are an invisible workforce, and the extent of their role is relentless, significant. They're virtually the nurse, doctor, physiotherapist, and those are the opportunities we see in what they do, and the skills that they're providing at the home, that needs to be highlighted and supported.
Yeah, and just again to emphasize the point, you can only get that through interviewing people. You cannot not get that information from administrative data. I've got the broad brush high level impacts. We can look at those sorts of things, maybe cost them. In terms of why and how much caring they're actually providing and what support they need, that's the sort of research that you're doing and others can contribute towards. Ben, yeah.
Just a quick, I know nothing about the topic, but it seems to me your research design has two interesting points. One is you're doing something that a lot of people don't do with the IDI, is distinguishing the ability to assess correlations and association and causality. And you've made a point about how you would think about causality. And I wonder whether you've got something that perhaps needs to be stressed a lot more in IDI type projects about the limits to which you can determine causality when you've got so many variables that you can't properly include that should be. But my second question is slightly more provocative, is given the huge difference in the prevalence of chronic issues that you talk about in the Pacific community, to what extent should you almost have a parallel project which looks at the sort of prior, how you're using all your prior knowledge to formulate what the sort of questions are that you want to get out of the data? I just wonder whether you've actually got such a hugely different issue that you need to think about it, or you might end up deciding you need to think about it quite differently. I mean, I like just it seems to me the way you're presenting it allows you to raise those cheeky questions, which we don't often do that well.
Yeah, so two questions there. I'll address the second one first, maybe about do we need to consider where either to undertake or do things differently for the Pacific population who are clearly differentially impacted. I mean, I'll say a couple of things there. One, they're differentially impacted for some conditions and under-impacted for others, but mostly they're over-impacted. And secondly, I think the fact that we've got Offa doing this alongside us, that can have some impact on the work we're doing. Offa's focusing specifically on the Tokelauan community. And Andrew Spall uses the word foundational. That might be a foundational study to work with other Pacific and non-Pacific populations as well. Might we decide by the end of it, and it's a relatively short project, 2 year, that we haven't serviced one population as well as we could, and we need to do more research? Quite possibly. We'll just have to see. In terms of the causality, you're absolutely right. We can do the best we can. In the application, I suggested that we can do some sort of matching on the sort of things you can match on, but that's about the extent of it. So it's going to be a bit the same with the prisoner reoffending research as well. We can get so far without getting to the point where we can necessarily say it's causal. Something else that's been occurring to me recently is in the zest to go towards causal methodologies, sometimes you're forced to not look at the correct causal model. And this came out of the study that I reported on last year on the lack of association we were seeing between household poverty and hospitalizations in children, where we're looking for a causal association by doing things a certain way, looking at change in poverty over time as it affects change in hospitalizations over time. Maybe that's not the right causal model. So I think you're absolutely right, but I think there's still value in doing what we do, and a different type of research might need to be done to look at causality.